the cardiovascular system. And this is an area where, I mean, it all collides, right? Embryology, physics, chemistry, physiology. It's arguably the most high-yield, densely packed, and complex system in human biology.
It absolutely is. It's the ultimate convergence point. For anyone trying to get a systemic, well-informed view of medicine, the heart is really where you have to start.
Right.
And our sources, they really demand that we don't just memorize definitions, we have to connect the dots.
Yes.
We need to understand the mechanism behind the murmurs, the rationale for, drug selection and heart failure, and the actual physics governing blood flow.
Exactly.
So this deep dive, it's designed as a shortcut. We're pulling out those crucial high-yield insights, everything from how the Starling curve works to the clinical implications of the funny current.
Our mission here is to slow the pace down and give those nuggets of knowledge time to actually land. We're trying to cut through the sheer volume of data and make sure that every complex concept, like the intricate steps of septation or the nuances of antiarrhythmic classes, is grounded in a real, intuitive understanding of why it works that way. We want you to walk away with a truly systemic view of the heart and circulation. Okay, let's unpack this, starting right at the very beginning. How the heart is built. The very idea that the heart is the first functional organ to develop it's just mind-boggling.
It is.
Our sources note that this spontaneous beating starts incredibly early. We're talking by week 4 of development.
That's right. It's like the body decides before we do anything else, we need circulation.
We need flow.
That speed just speaks volumes about the biological necessity of it.
Yeah.
And, the very first architectural challenge the embryo faces is moving from a simple tube to a 4-chamber pump. And that process begins with what we call cardiac looping. The primary heart tube, which is straight at first, it folds and twists upon itself.
And this twisting, this looping, that's what sets up the fundamental layout, the left-right asymmetry.
Precisely. If that twisting motion, which kicks off in week 4, gets disrupted, the entire body plan can be affected.
And the clinical consequence is pretty stark.
Oh, absolutely. Dextrocardia.
Yeah.
The heart ends up on the right side of the chest.
Yeah.
And it's often part of a broader ciliary dysfunction syndrome, like Cardigainer syndrome.
Which tells you that the fundamental mechanisms governing that left-right patterning were flawed from the start.
Exactly.
Okay, let's move to the complex construction job, septation. Dividing the atria and the ventricles. The atrial division, it seems to involve structures that appear and then regress, almost like temporary scaffolding.
It's a really intricate 4-step process. The first structure is the septum primum. Think of it as a crescent-shaped sheet growing downward toward the endocardial cushions.
Okay.
It leaves an initial opening near those cushions called the ostium primum. But here's the clever part. The superior portion of that septum primum undergoes programmed cell death.
Apoptosis.
Right. It creates a new hole higher up, the ostium secundum, before the ostium primum has fully closed.
So wait, for a brief period, the heart has 2 openings in the atrial wall.
Functionally, yes. It's a brilliant bit of timing. Then the second structure, the sectum secundum, grows alongside the first, but on the right side.
Okay.
And it expands to cover most of that ostium secundum. The opening that's left over is the foramen ovale.
And the septum primum acts as the valve.
That's the crucial part. The remaining part of the septum primum acts as the valve for the foramen ovale, ensuring flow is strictly right to left during fetal life.
That flap mechanism is the perfect setup for the most common structural anomaly we find in adults, the patent foramen ovale, or PFO.
Exactly. If that flap, the septum primum, fails to fuse permanently against the septum secundum after birth, you have a PFO.
And the sources highlight that this is incredibly common.
Incredibly. We're talking about 25% of the general population. And it's usually harmless.
Why is it harmless most of the time, and when does it actually become a hazard?
Well, it's harmless because postnatally, the left atrial pressure is substantially higher than the right, thanks to the fully operational pulmonary circulation.
So the pressure gradient keeps it sealed shut.
That high left-sided pressure keeps the flap pressed shut, exactly. The hazard arises only when that pressure gradient temporarily reverses.
Like during a forceful cough or something?
A sudden forceful cough, straining, a Valsalva maneuver. If the right atrial pressure exceeds the left in that moment, a venous clot, a thromboembolism that should have been filtered by the lungs can
slip right through.
It can paradoxically cross the PFO directly into the systemic circulation and cause a stroke. That's the definition of a paradoxical embolus.
Okay, now ventricular septation. This seems less about temporary flaps and more about solid structures fusing with those spiraling outflow tracts.
You're right. The muscular interventricular septum forms first, but it doesn't meet the endocardial cushions completely.
So there's a gap.
There's a gap. And the real complexity, and the source of many common defects, is closing that gap to form the membranous interventricular septum. This is formed by the fusion of the muscular septum, the endocardial cushions, and crucially, the aorticopulmonary septum.
And if that fusion process is flawed, you get the most common congenital defect.
A ventricular septal defect, or VSD. It's the most common congenital anomaly, and it often occurs right in that membranous region.
And what about AVSDs?
Atrioventricular septal defects, or AVSDs, involve the endocardial cushions themselves, so they affect both atrial and ventricular septation. AVSDs are the classic cardiac defect we associate with specific genetic syndromes like Down syndrome, but also with lifestyle factors like maternal diabetes and obesity.
Let's talk about the vessels themselves, the plumbing. How do the aorta and pulmonary trunk manage to separate and spiral around each other like that? It's remarkable.
It's one of the most incredible cellular migrations in all of embryology. Specialized cells, neural crest cells, they migrate into the region to form the truncal and bulbar ridges. These ridges have to spiral as they grow and fuse down the middle. That spiraling separates the single outflow tract into the pulmonary trunk and the ascending aorta.
And the spiral ensures the right connections.
It ensures that the aorta connects to the left ventricle and the pulmonary trunk connects to the right. It's a perfect architectural solution.
So what happens when those neural crest cells fail to migrate correctly, or if that spiraling just doesn't happen?
The clinical consequences are severe. They're known collectively as conotruncal abnormalities.
Right.
So a failure to spiral results in transposition of the great arteries, or TGA. The aorta arises from the RV and the pulmonary artery from the LV.
You get two closed loops.
Two parallel isolated circulations. It's immediately cyanotic and, lethal without surgical intervention or an immediate shunt. Other failures lead to things like tetralogy of Fallot and persistent truncus arteriosus.
Before we move on, I want to briefly revisit the anatomical remnants. Postnatal derivatives are often overlooked, but they tell the story of that transition from a, water-based to an air-based circulation.
Absolutely. Think of them as historical markers. The ductus arteriosus, which is the fetal bypass highway, it collapses and forms the ligamentum arteriosum.
And clinically, that's important because of the nerve that wraps around it.
Precisely. It's right near the recurrent laryngeal nerve, which is why heart surgery in that area can sometimes cause hoarseness. The ductus venosus, which bypassed the liver, becomes a ligamentum venosum.
Then the umbilical vessels.
They collapse too. The umbilical arteries form the medial umbilical ligaments, and the vein becomes the round ligament of the liver. Every single one of these transformations is a physiological declaration that the fetus is now an independent, air-breathing organism.
Here's where it gets really interesting. The three crucial shunts that redefine circulation in the fetus. We're shifting from a system based on getting maximum oxygen to the head to a system that processes oxygen in the lungs.
The fetal circulation is all about efficiency in a low-oxygen environment. The goal is simple. Ensure the most highly oxygenated blood bypasses the unnecessary lungs and liver to feed the developing brain.
And the three shunts, ductus venosus, foramen ovale, and ductus arteriosus, are the mechanism for this bypass.
They're the whole mechanism.
So walk us through that specific path of the most oxygenated blood.
Okay, so blood arrives highly oxygenated from the placenta via the umbilical vein. It immediately encounters the ductus venosus, which shunts it directly into the inferior vena cava, the IVC.
Bypassing the liver.
Bypassing the hepatic circulation entirely. From the IVC, it enters the right atrium. Now, due to some very clever directional flow patterns, that most oxygenated stream preferentially crosses the foramen ovale into the left atrium.
And from there to the brain.
From the LA to the left ventricle, and then it's pumped into the ascending aorta, supplying the coronary arteries in the head and neck.
So the fetal brain really does get the best stuff. What about the rest of the blood, the deoxygenated blood coming back from the body?
The less oxygenated blood, mostly returning from the superior vena cava, the SVC, from the upper body, it heads to the right ventricle. The RV pumps it into the pulmonary artery.
But the lungs are collapsed.
They're collapsed and non-functional. So pulmonary vascular resistance is extremely high. This high resistance forces most of that blood to exit the pulmonary artery and shunt directly through the ductus arteriosus into the descending aorta.
So the lungs are bypassed again, and that blood goes back to the placenta.
Exactly. It returns to the placenta for reoxygenation via the umbilical arteries.
That transition at birth is monumentally fast. What is the trigger that instantly shuts down this beautifully engineered bypass system?
Birth is characterized by two massive simultaneous pressure shifts. First, you clamp the umbilical cord. That removes the low-resistance placental circulation, which instantly increases systemic pressure.
Okay.
Second, the baby's first breath. That causes a huge influx of oxygen, which acts as a powerful vasodilator in the lungs, and the pulmonary vascular resistance just plummets.
And that flips the whole pressure gradient.
It flips everything.
Yeah.
LA pressure skyrockets above RA pressure, which functionally slams the foramen ovale shut. And crucially, the rise in oxygen and the withdrawal of placental prostaglandins cause the ductus arteriosus to constrict.
The prostaglandins are key here, aren't they? They're what keep the duct open.
That's right. Prostaglandins E1 and E2 are powerful vasodilators that maintain the patency of the ductus arteriosus in utero.
So if a patent ductus arteriosus, a PDA, persists after birth,
We can administer NSAIDs, like indomethacin, which inhibit prostaglandin synthesis. That can help pharmacologically close the duct.
let's quickly review the major anatomical landmarks of the adult heart, because chamber enlargement often leads to predictable clinical signs based on what the chamber is sitting next to.
The posterior location of the left atrium is a classic example. If the LA enlarges, which is common in chronic mitral stenosis, it can compress the adjacent esophagus,
Causing dysphagia?
causing dysphagia, difficulty swallowing. Even more uniquely, extreme LA enlargement can compress the left recurrent laryngeal nerve as it wraps around the aortic arch.
And that causes hoarseness, Ortner syndrome.
That's Ortner syndrome.
And the most vulnerable chamber is the one out front.
The right ventricle is the most anterior part of the heart, which unfortunately makes it the chamber most prone to penetrating injury or trauma.
And the pericardium.
A less common but important structural note are the layers of the pericardium, the fibrous outer layer, and the two serous layers, parietal and visceral or epicardium. And they're separated by the fluid-filled pericardial space. The sensory nerve supply to the pericardium is the phrenic nerve.
Which is why pericarditis pain is often referred to the shoulder.
Exactly.
Finally, coronary dominance. I think listeners often misunderstand what dominance actually means here. It's not about which artery is biggest, is it?
No, it's not. It's purely defined by which artery supplies the posterior descending artery, the PDA.
And why is the PDA so critical?
Because it feeds the posterior third of the interventricular septum, and that includes the AV node bundle branches. So it's critical for electrical conduction. Right dominant circulation, which is the vast majority, about 85% of people, means the PDA arises from the right coronary artery, the RCA.
So the key takeaway here is, if you occlude the dominant artery, you risk a catastrophic failure that's both mechanical and electrical.
Precisely. If someone has right dominant circulation and they suffer an RCA occlusion, they not only lose blood supply to the RV and the inferior LV wall, but they also likely lose blood supply to the SA and AV nodes.
Leading to bradycardia or heart block.
Exactly. That distinction dictates the immediate clinical approach to an MI.
Okay, moving from architecture to performance metrics. When we talk about the heart as an engine, we focus on stroke volume, SV, the volume ejected per beat. And SV is determined by three interacting factors: contractility, preload, and afterload.
These three are absolutely fundamental. You increase stroke volume by increasing contractility, increasing preload, or decreasing afterload. A failing heart, by definition, has a decreased stroke volume for a given afterload.
Let's unpack contractility or inotropy. How does the body tell the heart muscle to squeeze harder, independent of the volume it's dealing with?
The nervous system provides that instruction, primarily through catecholamines, acting on beta-1 adrenergic receptors.
A classic GIS protein pathway.
That's right. Beta-1 activation leads to adenyl cyclase, which increases KMP, which activates protein kinase A, or PKA.
And PKA gets the calcium moving.
PKA phosphorylation ultimately does two things. It increases calcium influx through L-type channels, and it accelerates the release of calcium from the sarcoplasmic reticulum, the SR. More calcium equals a stronger, faster contraction. It's that simple.
And what shuts that process down or weakens it?
Well, chronic conditions like systolic heart failure, hypoxia, acidosis, they all reduce contractility. Pharmacologically, non-dihydropyridine calcium channel blockers also inhibit that calcium entry, reducing the force generation.
This brings up one of the most fascinating indirect mechanisms in pharmacology, digoxin. Wait, so digoxin doesn't hit the calcium channel directly.
No, it doesn't.
It backs up the sodium pump, which then indirectly affects the sodium-calcium exchanger. That seems incredibly complex and almost inefficient.
It is brilliantly complex, and that slow, indirect action is exactly why it works. Digoxin inhibits the sodium-potassium pump on the cell membrane.
Right, the pump that drives potassium in and sodium out.
By inhibiting it, intracellular sodium concentration starts to rise. This increased intracellular sodium then changes the equilibrium of the sodium-calcium exchanger, the NCX.
Which normally pushes calcium out.
It normally moves sodium in and calcium out. With high internal sodium, the NCX slows down or even reverses, leading to a net increase in intracellular calcium. And that final step, the increased calcium available for the next beat, is what gives digoxin its positive inotropic effect.
Wow. Okay, now preload versus afterload. Preload seems easier to grasp. It's the volume stretch.
Preload is the stretch placed on the ventricular muscle fibers just before contraction. It's best approximated by the end diastolic volume, or EDV.
And it depends on venous return.
It depends on venous tone and circulating blood volume. If you vasodilate the veins, you pull blood away from the heart, which decreases preload. Afterload, however, is the wall stress the ventricle must overcome to eject blood.
Which is approximated by mean arterial pressure.
Mean arterial pressure and total peripheral resistance, TPR.
And the connection between afterload, size, and pressure is where Laplace's law lives.
Laplace's law is crucial for understanding how the ventricle adapts. It states that wall stress is proportional to the pressure times the radius, divided by 2 times the wall thickness.
So what's the real insight here?
The real insight is the heart's engineering response to chronic stress. When pressure goes up, like in chronic hypertension, the wall stress initially increases dangerously. To normalize that stress, to keep the strain on the individual muscle fibers at a manageable level,
The heart compensates.
it compensates by undergoing chronic hypertrophy. It increases the wall thickness. That is the beautiful compensatory mechanism that Laplace's law explains.
These factors all integrate into the master metrics: cardiac output, CO, and ejection fraction, EF.
Right. CO is simply stroke volume times heart rate. Stroke volume is EDV minus ESV, the end systolic volume.
And EF is the index of contractility.
EF, the ejection fraction, is the fraction of that EDV that gets ejected. So it's SV divided by EDV. A normal EF ensures efficient pumping.
And for research, there's the Fick principle.
Yes, for research or clinical moments requiring a very exact measurement, the Fick principle offers an elegant way to calculate CO indirectly. It's the body's oxygen consumption divided by the difference in oxygen content between arterial and venous blood.
No.
It connects metabolism directly to flow.
Before we hit the curves, let's quickly define MAP and pulse pressure.
MAP is the weighted average pressure, approximately 2/3 diastolic blood pressure plus 1/3 systolic. Pulse pressure, PP, is simply systolic minus diastolic.
And pulse pressure reflects stroke volume.
Stroke volume and the compliance, or stiffness, of the large arteries. If the arteries stiffen with age, or if SV increases dramatically, like in aortic regurgitation, the pulse pressure widens significantly. So now we can connect all these variables using the Frank-Starling mechanism. This is the heart's intrinsic ability to adapt.
The more you stretch it, the harder it snaps back.
The force of contraction is proportional to the initial fiber stretch, the EDV. If more blood comes in, the heart snaps back harder. It's an inherent property of the muscle.
But, as we said, contractility or inotropy is an extrinsic shift. This is best visualized by combining the Starling mechanism with the concept of vascular function.
This is a crucial section to master. We're looking at the intersection of the cardiac output curve and the venous return curve. The equilibrium point is where cardiac output equals venous return.
Okay, let's analyze the logic of the shifts. If we give a positive inotrope, like catecholamines from graph A, the heart just pumps more efficiently.
Right. The cardiac function curve shifts upward. The venous return curve, which primarily depends on systemic volume and resistance, it doesn't really change its physical position. So the new equilibrium point is simply a higher cardiac output at the same or slightly lower right atrial pressure. The heart is now the limiting factor on flow.
What if we increase the total volume, say, with a rapid fluid infusion, as in graph B?
That fluid infusion increases the mean systemic pressure, the MSP. That means the pressure gradient driving blood back to the heart is higher everywhere. So the entire venous return curve shifts to the right.
And the CO curve also benefits from the increased preload.
It does. So the new intersection point shows a higher cardiac output, but also a higher right atrial pressure, which reflects that volume overload.
And finally, changing total peripheral resistance, TPR, with a vasopressor, as in graph C.
Okay, TPR increases. This is a dual effect. It increases the afterload on the heart, which drops the cardiac function curve down. And it increases the resistance in the venous system, which changes the slope of the venous return curve. The net result is a new, lower cardiac output at a higher right atrial pressure because flow is being impeded by resistance, and the heart is struggling against that afterload. Understanding these three graphs is the key to predicting any hemodynamic change in the ICU.
Let's walk through the pressure-volume loop, the single-beat summary of cardiac mechanics. It visually integrates volume, pressure, and timing all at once.
The loop is always tracked in 4 phases, measuring left ventricular pressure versus volume. Phase 1 is isovolumetric contraction.
Which begins at S1 when the mitral valve closes.
Exactly. The volume's fixed at EDV, but the pressure rises steeply until it exceeds aortic pressure. Then phase 2, systolic ejection. The aortic valve opens, volume plummets as blood rushes out, ending at ESV. Pressure peaks and then drops.
And phase 3 is isovolumetric relaxation.
The aortic valve closes, that's S2. Volume is fixed again, now at ACV. And the pressure drops dramatically until it falls below the left atrial pressure. This is a crucial phase. If the ventricle is stiff, in diastolic dysfunction, this pressure drop is inadequate.
And that leads to phase 4, ventricular filling.
The mitral valve opens, and the volume increases back to EDV, ready for the next beat.
Connecting this physics to sound, heart sounds, S1 to S4, S1 and S2 are the standard valve closures.
Right. S1 is mitral and tricuspid closure. S2 is aortic and pulmonary closure. S3 occurs early in diastole. It sounds like a sudden deceleration of blood entering an already full ventricle.
A volume problem.
It's a sign of increased volume or pressure in the LA, commonly associated with systolic heart failure, HFrEF.
And S4, the atrial kick.
S4 is late diastolic, just before S1. It's the sound of the atrium contracting and trying to force blood into a stiff, non-compliant ventricle. It is highly associated with ventricular hypertrophy and diastolic heart failure, HFpEF.
Is there a mnemonic for that?
A good one is S3 is VOL for volume overload. S4 is STIFF for a stiff ventricle.
The splitting of S2 is a brilliant diagnostic tool. Physiologic splitting is only heard on inspiration because inspiration does what to RV filling?
Inspiration lowers intrathoracic pressure, which slightly increases venous return specifically to the right heart. This increased volume increases the RV stroke volume, which takes a little longer to eject.
So it delays the pulmonary valve closing.
It slightly delays P2, the pulmonary valve closure, relative to A2, the aortic valve closure, and it closes completely on expiration.
So if we see wide splitting.
Wide splitting means that P2 delay is exaggerated and persistent. It's caused by anything that chronically delays RV emptying, like a right bundle branch block or pulmonic stenosis.
And fixed splitting is the classic sign of a volume overload that's independent of respiration.
That's the ASD hallmark. The constant left-to-right shunt perpetually volume loads the RV, constantly delaying P2, regardless of whether the patient is breathing in or out.
And paradoxical splitting, the most confusing one, is heard on expiration and disappears on inspiration.
This happens when A2 is delayed. Causes include aortic stenosis or a left bundle branch block.
How does that work?
On expiration, the delayed A2 occurs after P2. Then, on inspiration, P2 shifts later, as it normally does, moving closer to the already delayed A2. It effectively merges the two sounds and eliminates the split. That's the paradox.
We can't conclude physiology without looking at the jugular venous pressure tracing, the JVP, which gives us a non-invasive window into right heart pressure dynamics.
The JVP tracing maps the subtle pressure changes in the right atrium. The A wave is atrial contraction. The C wave is the isovolumetric RV contraction, pushing the tricuspid valve back into the atrium.
Okay.
The V wave is the atrium filling against a closed tricuspid valve. The X descent is atrial relaxation. And the Y descent is the rapid ventricular filling when the tricuspid valve opens.
How does pathology change this normal pattern? If we have atrial fibrillation, we lose the coordinated squeeze.
Loss of coordinated atrial contraction means the A wave is absent. In tricuspid regurgitation, the RV contraction forces blood back into the RA during systole, so the C and V waves merge into a huge, prominent CV wave. It's often called a cannon wave.
A big backward push.
Exactly. And the most diagnostic finding in conditions where the heart is restricted, like cardiac tamponade.
What do we see there?
In tamponade, fluid is compressing the heart. The atria can still contract, so the A wave is present, and they can relax, so the X descent is present. But when the tricuspid valve opens, the ventricle cannot physically expand because of that external compression. It can't suck blood in effectively.
So the Y descent, the filling phase, is gone.
It's severely blunted or entirely absent. A prominent X descent, but an absent Y descent, is highly suggestive of tamponade or constrictive pericarditis.
Okay, transitioning to pathology. We focus first on listening auscultation and using physiological maneuvers to manipulate murmurs. The key insight is understanding how volume, or preload, and resistance, afterload, change the dynamics of blood flow.
This is a really high-yield clinical skill. We have to understand the effect of, say, a Valsalva or standing up versus squatting or leg raise.
Let's start with Valsalva or standing up quickly. This dramatically decreases venous return, right? So it drops both preload and afterload. Generally, this quiets most murmurs just due to reduced flow.
But the two exceptions that get louder are the clinical gems: mitral valve prolapse, MVP, and hypertrophic cardiomyopathy, HCM.
Why is that?
In MVP, decreasing the volume shrinks the LV cavity, making the redundant mitral leaflets prolapse earlier, so the click moves earlier and the murmur gets longer and louder.
And in HCM?
In HCM, the smaller LV cavity actually increases the obstruction in the outflow tract, which makes the turbulent flow louder.
Now the opposite, squatting or a passive leg raise.
Both of those actions increase preload and afterload. This increases flow across most valves, making most murmurs louder. But crucially, in MVP and HCM, the increased volume stretches the ventricle, which reduces the obstruction, and so it makes those specific murmurs quieter.
What about the hand grip maneuver, which specifically isolates afterload?
Hand grip increases SVR massively. This makes it harder for the LV to eject, so it increases the intensity of murmurs driven by systemic reflux or post-ejection flow.
Like AR and MIMR?
Specifically aortic regurgitation, mitral regurgitation, and VSD. The higher systemic pressure forces more blood back across those leaky valves. Conversely, it decreases the murmur of aortic stenosis because the heart just can't push blood across the stenotic valve against such high resistance.
Let's look at the specific murmurs. Aortic stenosis is the classic systolic crescendo-decrescendo murmur.
Right, it's a systolic ejection murmur, and it radiates to the carotids. It reduces stroke volume, leading to that classic SAD triad: syncope, angina, and dyspnea on exertion.
And its common cause is just age-related wear and tear.
Age-related calcification, yeah, though it's often accelerated by a congenital bicuspid aortic valve.
Mitral regurgitation is holosystolic.
It's a high-pitched, blowing holosystolic murmur. You hear it best at the apex, and it radiates to the axilla. It's caused by damage to the valve apparatus, often post-MI from a papillary muscle rupture, or LV dilation or rheumatic fever.
And VSD is also holosystolic.
Yes, but it's harsh-sounding, and you hear it best at the tricuspid area.
Okay, moving to diastolic murmurs. Aortic regurgitation.
AR is an early diastolic, decrescendo, high-pitched blowing murmur. Because the blood is flowing backward during diastole, the diastolic blood pressure drops precipitously.
Which leads to a wide pulse pressure.
A wide pulse pressure and characteristic signs like bounding pulses.
Mitral stenosis.
Mitral stenosis is almost universally caused by prior rheumatic fever. It's characterized by the S2 sound, followed immediately by an opening snap, an OS, and then a rumbling mid to late diastolic murmur.
And the timing of the snap tells you about severity.
Exactly. The shorter the S2 to OS interval, the more severe the stenosis, because a high LA pressure forces that valve open faster.
Okay, the congenital murmurs left to right shunts are acenotic at presentation, VSD, ASD, PDA. The problem isn't a lack of oxygen, it's volume overload.
That's the whole problem. The high-pressure systemic circulation shunts blood into the low-pressure pulmonary circulation. This chronic volume overload leads to pulmonary hypertension and eventually right-sided heart failure.
The classic sign of ASD we noted is that fixed splitting of S2. What about a PDA?
The patent ductus arteriosus gives you that continuous machinery-like murmur. If this shunt remains uncorrected, the chronic overperfusion of the lungs causes irreversible vascular remodeling.
And eventually the shunt reverses.
Eventually, the pulmonary vascular resistance exceeds the systemic resistance, causing the shunt to reverse from right to left. That is Eisenmenger syndrome. It presents with late cyanosis, clubbing, and polycythemia.
Now, the RL shunts the cyanotic heart diseases, the blue babies, the 5 Ts, truncus arteriosus, transposition, tricuspid atresia, tetralogy of Fallot, and TAPVR. Let's zero in on tetralogy of Fallot, the most common cyanotic lesion.
Tetralogy is really a single developmental failure. Anterosuperior displacement of the infundibular septum. That one error creates 4 distinct defects.
What are they?
1, pulmonary valve or infundibular stenosis, PS2, right ventricular hypertrophy, RVH. 3, a VSD. And 4, an overriding aorta.
And the severity of the pulmonary stenosis dictates the whole clinical picture.
It is the main determinant of cyanosis. During an acute TET spell, which is usually triggered by crying or exertion, the RV outflow tract spasms, which increases the stenosis.
So more blood shunts right to left.
It dramatically increases pressure in the RV, forcing deoxygenated blood across the VSD right to left, causing acute cyanosis. Squatting helps because it increases systemic resistance, SVR.
Making it harder to shunt the blood.
It makes it harder to shunt RL, which momentarily forces more blood through that narrow pulmonary stenosis and into the lungs.
Another critical defect, coarctation of the aorta. The narrowing is usually juxtaductal.
Right. And coarctation is strongly associated with the bicuspid aortic valve and Turner syndrome. Because of the obstruction, patients present with classic differential symptoms: high blood pressure and strong pulses in the upper extremities.
And weak, delayed pulses in the lower extremities.
Yeah, clamminess, yes.
And the radiographic sign of compensation is one of the most memorable images in medicine.
Rib notching. The body develops extensive collateral circulation to bypass the stricture, specifically by dilating the intercostal arteries. The pulsatile force of these large, dilated intercostals actually erodes the inferior surface of the ribs.
And you can see it on a chest x-ray.
You can see it on a chest x-ray. It's a physical record of the body's attempt to overcome a structural flaw.
Okay, transitioning to adult pathology, atherosclerosis. This inflammatory process underlies most adult morbidity. Where does the damage begin?
It starts with endothelial dysfunction, often triggered by mechanical stress like hypertension or chemical stress like oxidized LDL or hyperglycemia.
And the progression is classic.
It is. LDL is oxidized within the intima, macrophages are recruited, they engulf the oxidized LDL, and they become foam cells. That's the fatty streak. That streak then matures into a fibrous plaque when smooth muscle cells migrate, proliferate, and deposit extracellular matrix, forming the cap.
The rupture of that cap is the moment of crisis.
When the fibrous cap ruptures, it exposes the highly thrombogenic core. That initiates the clotting cascade, which results in thrombus formation, depending on whether that thrombus is non-occlusive.
Unstable angina and STEMI.
Or occlusive. A STEMI, you get an acute coronary syndrome.
Let's touch on the smaller vessel disease, arteriolosclerosis. We distinguish hyaline and hyperplastic.
Right. Hyaline involves a homogeneous thickening of the arterial walls. It's due to plasma protein leakage, and you see it in benign hypertension or diabetes. Hyperplastic is far more severe, characteristic of malignant hypertension.
The onion skinning.
You see that concentric, laminated, smooth muscle cell proliferation that looks like onion skinning under the microscope, and it severely narrows the lumen.
Now, aortic pathology. Aneurysms are dilations. Dissection is a tear. Thoracic aortic aneurysms are often linked to Marfan syndrome or bicuspid valves. AAAs are linked to smoking.
Abdominal aortic aneurysms, AAAs, are typically infrarenal and are associated with massive risk factors: male, smoker, age. The rupture is catastrophic. It presents with that classic triad: a pulsatile abdominal mass, acute abdominal or back pain, and hypotension.
Aortic dissection is a different type of emergency, a longitudinal tear.
The patient presents with excruciating, severe, sharp, tearing chest pain that radiates the back. Hypertension is the primary risk factor.
And we use the Stanford classification for management.
We do. Type A involves the ascending aorta. It has a high risk of tamponade or rupture, so it requires urgent surgical repair. Type B is distal, involving the descending aorta, and that's managed medically with aggressive blood pressure control.
Specifically beta blockers.
Yes, beta blockers, to reduce the shear stress on the aortic wall.
We classify ACS based on stability and ECG troponin findings.
Right. Stable angina is pain relieved by rest or nitro, usually less than 70% stenosis. Unstable angina is acute pain not relieved by rest, but without a troponin elevation.
And STEMI is unstable angina with troponin elevation.
With troponin elevation, and usually ST depression or T-wave inversion on the ECG, a STEMI is the full thickness, transmural infarction, defined by ST elevation and eventually pathologic Q waves.
Here's where it gets really interesting. The microscopic timeline of an MI. The body's healing response is dangerous and highly timed.
This is vital because the complications are time-dependent. In the first 0 to 24 hours, you get early coagulation necrosis. The tissue is acutely dying. Death here is almost always due to electrical chaos, ventricular arrhythmias, or cardiogenic shock.
Okay, then days 1 to 3.
Neutrophils are swarming in, consuming the dead tissue. The complication here is inflammation over the tissue, fibrinous pericarditis.
Days 3 to 14 is the danger zone for rupture.
This is the softening phase. Macrophages are clearing the dead myocytes, and granulation tissue is starting to form, but the tissue is structurally at its absolute weakest. This is when the heart is vulnerable to rupture.
Free wall rupture, papillary muscle rupture.
Free wall rupture leading to fatal tamponade, papillary muscle rupture leading to acute MR, or a VSD from tearing of the septum.
And then, weeks to months later,
Scarring is complete. You have a dense gray-white scar. The complications now are chronic: a ventricular aneurysm with its risk of mural thrombus, or Dressler syndrome, which is a subacute autoimmune pericarditis.
For diagnosis, troponin is the preferred biomarker. How does its timing compare to CKMB?
Troponin I or T rises within 4 hours, it peaks at 24 hours, and it remains elevated for 7 to 10 days. That long duration makes it excellent for a late diagnosis.
But CKMB is better for reinfarction.
CKMB peaks earlier, but it returns to normal within 48 hours. That fast return to baseline makes CKMB the better choice if you suspect a patient is having a reinfarction a few days after their initial event.
All right, let's review the microscopic basis of the heartbeat, starting with the myocardial action potential, the AP, in the ventricles, the fast response.
The myocardial AP relies on fast sodium channels for that rapid depolarization. Phase 0 is the rapid upstroke. Fast sodium channels open. Phase 1 is initial repolarization. The sodium channels close.
And phase 2 is the plateau, the essential difference.
Yes, the calcium influx through L-type channels balances the potassium efflux. This plateau ensures a long refractory period, which prevents tetany and ensures mechanical contraction has time to occur.
And then phase 3 is rapid repolarization, and phase 4 is a stable resting potential.
Right. Calcium channels close, potassium efflux dominates, and then the cell rests.
Now, contrast this with the pacemaker AP of the SA and AV nodes, the slow response. This mechanism is fundamentally different and, well, relies on instability.
This is where the magic of self-initiation happens. They lack that stable phase 4 resting potential.
Right.
Their phase 4 is unstable. It's driven by the if current, the funny sodium channels. These channels are slowly permeable to sodium, causing a flow diastolic depolarization that automatically drives the cell to threshold.
So it just drifts up on its own.
It just drifts. And phase 0 is upsetting. Instead of fast sodium influx, the depolarization is driven by slow calcium influx through L-type channels. This calcium-dependent depolarization is much slower than the sodium-dependent one, which is why the AV node conducts so slowly.
The conduction pathway dictates the timing of the squeeze. That crucial 100-millisecond delay happens where and why.
The SA node is the boss, but the AV node is the gatekeeper. That AV node delay is physiologically vital. It ensures that the atria finish contracting and filling the ventricles before the ventricles begin their powerful contraction.
And conduction is fastest in the Purkinje fibers.
Fastest in the Purkinje system, slowest at the AV node.
Mapping this to the ECG. P wave, QRS, T wave.
P wave is atrial depolarization. The PR interval, which is normally 120 to 200 milliseconds, measures the time it takes for the impulse to get from the atria through that slow AV node to the ventricles.
QRS is ventricular depolarization.
And contraction. The T wave is ventricular repolarization. And the ST segment, normally isoelectric, is the key marker for transmural ischemia, ST elevation, or subendocardial ischemia, ST depression.
Let's categorize the chaotic rhythms. We'll start with atrial fibrillation, AFib. Irregular, no discrete P waves.
AFib originates from chaotic electrical activity, often starting near the pulmonary vein ostia. The AV node is just bombarded with impulses, which results in that irregular ventricular response.
And management is all about rate control and stroke prevention.
Always. Rate control with beta blockers, calcium channel blockers, digoxin, rhythm control with antiarrhythmics. But the primary concern is stroke risk due to static blood flow and clot formation in the LA appendage. That requires long-term anticoagulation.
Okay, Wolff-Parkinson-White WPW syndrome seemed highly counterintuitive. If the goal in tachycardia is to slow the heart, why is blocking the AV node with a drug like adenosine potentially fatal in this case?
That's the critical high-yield paradox of WPW. The syndrome is defined by the bundle of Kent, an accessory pathway that is faster than the normal AV node.
So you see a short PR and a delta wave.
A short PR, a wide QRS, and the delta wave. Now, if a patient with WPW goes into AFib or flutter, and you give them an AV node blocker like adenosine, digoxin, a beta blocker, or verapamil, you are essentially shutting down the normal slow route.
Which forces everything down the fast lane.
It forces all the chaotic atrial impulses to travel down the fast accessory pathway directly to the ventricles. This can cause the ventricular rate to accelerate dangerously fast, precipitating ventricular fibrillation and sudden cardiac death.
So you treat it with crocanamide.
Procainamide, or you ablate the pathway.
Torsades de pointe, the twisting of the points, a polymorphic VT caused by QT prolongation.
Torsades is a life-threatening rhythm. It's characterized by a shifting sinusoidal ECG waveform. It's caused by anything that prolongs the QT interval, which means prolonged ventricular repolarization, phase 3.
And a lot of common drugs can do this.
A lot. Common culprits are genetic predisposition, or it's acquired through drugs, class IA and 3 antiarrhythmics, certain antibiotics like macrolides, antipsychotics, antidepressants.
And the treatment is very specific.
The acute treatment, even for a stable patient, is 48 magnesium sulfate.
Finally, the conduction blocks of the AV node. We have 3 degrees.
Right. First degree is just a prolonged PR over 200 milliseconds, usually benign. Second degree Mobitz type 1, or Weckenbach, is the progressive lengthening of the PR interval until a beat is dropped, also usually benign.
But Mobitz type 2 is not benign.
Mobitz type 2 has dropped beats without any preceding PR lengthening. This is a structural problem, typically below the AV node, and is dangerous because it can progress rapidly to a third-degree block. It often requires a pacemaker.
And third degree, or complete, AV block.
That's complete dissociation between the P waves and the QRS complexes. The atria and ventricles are beating independently. The ventricles rely on a very slow escape rhythm, which mandates immediate pacemaker placement.
Okay, moving to heart failure, HF. Let's start with the 2 main cardiomyopathies, dilated versus hypertrophic.
Dilated cardiomyopathy, DCM, is the most common. The ventricles are floppy and ballooned out. This leads to systolic dysfunction, or HFrEF, with a reduced ejection fraction.
And the causes are diverse.
Very diverse. It can be genetic, often a TTN gene mutation, or from alcoholism, cocaine, or even Chagas disease. The classic finding is an S3 gallop due to that volume overload.
And hypertrophic cardiomyopathy, HCM, is often genetic and frequently autosomal dominant.
HCM involves a thickening of the ventricular walls, particularly the septum. This causes diastolic dysfunction, or HFpEF, because the stiff, non-compliant ventricle can't fill properly.
And if it obstructs the outflow tract?
If the septum obstructs the LV outflow tract, it's called HOCM. The risk of sudden cardiac death is paramount, which makes avoiding aggressive, high-intensity exercise a critical instruction for these patients.
And treatment focuses on maximizing filling time.
Beta blockers, or calcium channel blockers, to decrease contractility and slow the heart rate, maximizing that filling time.
When we define heart failure as a syndrome, we're really focusing on the clinical consequences of the pump dysfunction, congestion, and low perfusion.
The symptoms often trace right back to pressure backup. Left-sided failure leads to pulmonary congestion, orthopnea, dyspnea on exertion. Right-sided failure leads to systemic congestion, jugular venous distension, peripheral edema.
And the cruel twist of chronic HF is that the body's attempt to compensate is what drives the vicious cycle of remodeling and worsening failure.
The neurohumoral response is the enemy in the long run. When cardiac output falls, the sympathetic nervous system and the RAS activate. They boost blood pressure and maintain perfusion temporarily.
But
chronic activation of RAS and catecholamines leads to fibrosis, pathological hypertrophy, and increased afterload on both ventricles. The resulting cardiac remodeling ultimately worsens the very failure they were trying to fix.
So treatment focuses on breaking that cycle.
Using ACE inhibitors, ARBs, and beta blockers to break that cycle.
Let's analyze the catastrophic failure state, shock. Defining inadequate perfusion using that hemodynamic table is key. We need to explain the logic of the pressure readings.
This table forces you to synthesize everything. We track key CWP, which is a proxy for LA pressure and preload, CVP for RA pressure and preload, cardiac output, and SVR for afterload.
Okay, hypovolemic, shock, pure, volume loss.
If you lose volume, all your central pressures drop. So low PCWP, low CVP, cardiac output drops. The body's immediate maximal compensation is to vasoconstrict to save the core organs, so SVR is very high.
Cardiogenic shock pump failure.
The pump fails, so blood backs up. Both central pressures are high PCWP, high CVP. Cardiac output is low. But the body still perceives low perfusion and responds by maximally vasoconstricting, so SVR is high. Patients are classically cold and clammy.
Obstructive shock, something blocking flow.
Mechanically blocked flow, like a PE or tamponade, causes backup, so PCWP and CVP are high. CO is low. And SVR is high due to compensatory vasoconstriction.
Finally, distributive shock septic or anaphylactic. This is often confusing because the cardiac output can be high.
It's counterintuitive that CO can be high, but that's because the system is so wide open due to massive vasodilation. SVR is the lowest of all shock states.
Right.
The central pressures drop because there's no pressure to maintain venous return. The heart, pumping against almost zero resistance, may compensate by dramatically increasing its output, resulting in a high CO. Patients present with warm, flushed skin due to that lack of peripheral vasoconstriction.
Let's detail one crucial obstructive shock cause, cardiac tamponade. The Beck triad is the classic clinical finding.
Beck triad: hypotension, distended neck veins, which is a high JVP, and distant, muffled heart sounds. Tamponade causes diastolic pressure equilibration across all four chambers because the external pressure limits filling.
And the accompanying sign, pulsus paradoxus, is often difficult to grasp conceptually.
It's a fall in systolic blood pressure by more than 10 millimeters of mercury during inspiration.
So why does that happen?
During inspiration, the increased venous return to the RV is accommodated only by pushing the interventricular septum to the left, which encroaches upon the LV volume. This transient decrease in LV filling leads to a temporary reduction in LV stroke volume, and therefore a measurable drop in systolic blood pressure.
Okay, moving to infections. Infective endocarditis. We split it into acute and subacute forms.
Acute is rapid and destructive, often caused by virulent organisms like S. aureus infecting previously normal valves. Subacute is gradual, usually caused by organisms like viridin streptococci infecting previously damaged valves, like from prior rheumatic fever.
And tricuspid valve endocarditis is a hallmark of IV drug use.
Highly associated with IV drug use, typically due to S. aureus.
The systemic clinical findings are often highly specific due to immunologic reactions and microemboli.
The clinical findings are categorized by the mnemonic from Jane. You get Roth spots in the retina, Osler nodes, which are painful nodules on the fingertips from immune complex deposition, Janeway lesions, which are painless emboli on the palms, and splinter hemorrhages.
Distinguishing Osler nodes from Janeway lesions is a classic distinction.
Osler are immune and painful, Janeway are embolic and painless.
And we can't discuss valvular disease without addressing its primary infectious precursor, rheumatic fever.
RF is a non-suppurative sequel of a pharyngeal infection by S. pyogenes. It's a classic example of molecular mimicry. Antibodies generated against the streptococcal M protein cross-react with host antigens, specifically the myosin in the heart muscle and the joints.
And it wrecks the valves.
It affects the valves. Mitral is most common, followed by aortic.
The diagnosis relies on the Jones criteria.
Right, the major criteria. Joints for migratory polyarthritis, the O shaped like a heart for carditis, nodules, erythema marginatum, which is a rash, and sydenham chorea, which is involuntary movements.
Finally, acute pericarditis. What differentiates this chest pain from an MI?
The pain is sharp, it's pleuritic, and it's classically relieved by sitting up and leaning forward. The ECG signature is diffuse ST segment elevation across multiple leads, unlike the localized, territory-specific ST elevation you see in a STEMI.
We wrap up with the pharmacological toolkit. Treating hypertension is highly customized based on comorbidities.
The baseline for primary hypertension is thiazide diuretics, ACE inhibitors or ARBs, and calcium channel blockers. But the clinical context is what drives the drug selection.
Give us those key selection rules.
For hypertension with heart failure, we use ACE inhibitors, ARBs, beta blockers, and aldosterone antagonists. Those are the drugs proven to reduce mortality by counteracting that vicious cycle of remodeling.
And if the patient has diabetes or kidney disease?
ACE inhibitors, or ARBs, are preferred because they reduce intraglomerular pressure, which provides renal protection. In pregnancy, the safe drugs are the HMLN mnemonic, hydralazine, methyldopa, labetalol, and nifedipine.
Next, anti-angiotensin and vasodilator drugs. The mechanism is simple. Reduce myocardial oxygen demand, MVO2.
Nitrates are key here. They generate nitric oxide, NO, which increases CGMP and causes smooth muscle relaxation. They preferentially vasodilate the veins,
which significantly decreases preload.
Exactly. That reduces the stretch on the heart and lowers its oxygen demand. Side effects like headache and reflex tachycardia are common, and they require a nitrate-free interval to avoid tolerance.
Calcium channel blockers are split based on where they focus their action.
Dihydropyridines, like amlodipine and nifedipine, are the vascular selective drugs. They cause arteriolar vasodilation, primarily reducing afterload. We use them for hypertension and Raynaud's.
And the non-dihydropyridines.
Verapamil and diltiazem. They are the cardiac selective drugs. They block L-type channels in the SA and AV nodes, decreasing heart rate and conduction velocity. This makes them ideal for rate control in AFib or flutter.
Hydralazine is another key afterload reducer.
Hydralazine is an arteriolar vasodilator that decreases afterload. It's often used in a hypertensive crisis or, notably, combined with nitrates in severe heart failure in certain populations. The primary risk is drug-induced lupus syndrome.
Let's discuss lipid-lowering agents. LDL is the core target.
Statins are the absolute foundation. They inhibit HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis. By forcing the liver to reduce internal production, it upregulates LDL receptor recycling, clearing huge amounts of LDL from the blood.
And the main side effects are liver and muscle related.
Hepatotoxicity and myopathy are the chief concerns.
How does ezetimibe add value?
Ezetimibe prevents cholesterol absorption in the gut. It's synergistic with statins because it targets a completely separate pathway.
Fibrates focus on triglycerides.
Fibrates, like gemfibrozil, activate PPAR-alpha, which increases LPL activity, dramatically lowering triglycerides. You have to be cautious when combining them with statins because of the increased risk of myopathy and rhabdomyolysis.
And the newest, highly potent LDL-lowering class, PCSK9 inhibitors.
These are monoclonal antibodies. They function by preventing the degradation of LDL receptors. This allows more receptors to remain active on the liver surface, leading to maximal LDL clearance from the blood. They're reserved for high-risk patients who can't reach their target goals with statins alone.
So what does this all mean? We have 4 classes of antiarrhythmics, the Sicilian gang of heart rhythm control, classified by the Vaughan-Williams system based on the channels they block.
Right. Class I blocks sodium channels, slowing conduction. Class II blocks beta receptors. Class III blocks potassium channels. And Class IV blocks calcium channels.
Let's focus on the distinctions within Class I, the sodium blockers.
Class IA, like quinidine and procainamide, have an intermediate binding speed. They increase the action potential duration and the ERP. Class IB, like lidocaine, have the fastest binding. They preferentially target ischemic depolarized tissue.
So they're best post-MI.
They actually decrease the action potential duration, making them the best choice for ventricular arrhythmias post-MI. Class IC, like flecainide, have the slowest binding. They severely slow conduction but have minimal effect on AP duration.
And there's a huge warning with these.
The key clinical takeaway is their danger. They are contraindicated in structural or ischemic heart disease because they increase mortality. They can cause proarrhythmia in already damaged tissue.
Class 2 are the beta blockers, working on the SA and AV nodes to decrease the slope of phase 4 depolarization, used for rate control in AFib.
Class 3 are the potassium channel blockers like amiodarone and sotalol. They prolong the action potential duration and the ERP. This increases the QT interval and raises the risk of torsades.
And amiodarone is in a class of its own.
It is. Amiodarone has class 1, 2, 3, and 4 blocking properties combined, making it highly effective. However, it's extremely lipophilic and has severe systemic side effects, pulmonary fibrosis, hepatotoxicity, and thyroid dysfunction due to its high iodine content.
And class 4 are the non-dihydropyridine calcium channel blockers, diltiazem and verapamil.
Primarily used for rate control in AFib and flutter because they decrease AV node conduction velocity, which increases the PR interval in the ERP.
A final word on digoxin, beyond its inotropy, its toxicity.
Digoxin has a very narrow therapeutic window. Toxicity often presents with nausea, vomiting, diarrhea, and the classic pathognomonic visual symptom, blurry yellow vision or xanthopsia. Clinically, toxicity often causes increased automaticity, leading to arrhythmias like premature ventricular contractions.
Yeah.
## outro.
We have completed an exhaustive deep dive, covering the cardiac system from its very first spontaneous twitch to the targeted biochemistry of modern drug interventions. We saw the inherent complexity in the embryonic construction, the elegant physics governing flow and pressure in the Frank-Starling mechanism, and the timed danger of MI complications.
You now hold the mechanistic understanding that makes those isolated facts stick. You know why a fixed S2 implies volume overload, why ACE inhibitors help heart failure patients by breaking that neurohumoral vicious cycle, and why specific antiarrhythmics are contraindicated post-MI.
Right.
This ability to connect the electrical, mechanical, and pharmacological threads, that's the core high-yield takeaway.
That brings us back to the heart's fundamental electrical identity. We saw that the heart's intrinsic rhythm relies on the funny current, the if in the SA node, a current driven by sodium channels that are fundamentally designed to be unstable, constantly leaking and driving the cell toward depolarization. Why didn't evolution settle on a chemically triggered start-stop mechanism? Considering that the biological imperative for continuous, spontaneous life relies on this underlying electrical instability, what does the necessity of that constant slow leak tell us about the inherent tension between absolute control, a stable, predictable state, and the chaotic requirement for continuous, self-initiating biological function? It's a mechanism designed to fail safely into life, something to think about as you review the rest of your source material.